All right, I want to welcome everyone to Baycare Presents. I'm very excited this month. We have Dr. Reichley with us, and he is going to be talking about recognizing the early warning signs of head and neck cancers. So I am going to turn it over to him, let him share who he is and his wealth of knowledge that he has for us. Dr. Reichley, it is for you.
Hi there, my name is Dr. William Reichley. I'm a head and neck surgical oncologist here in Clearwater and serving the Pinellas, Hillsborough, Pasco, and Hernando areas. And today we'll be talking about recognizing early warning signs of head and neck cancer. First off, I have no disclosures and no conflicts of interest that would affect the presentation of this discussion. First, we'll talk about our learning objectives. So most importantly, why is early detection of head and neck cancer important? We'll talk about how prevalent it is, as well as survival statistics and some cost analysis, as well as a quick discussion of the anatomy and risk factors, as well as, most importantly, red flags you can't miss. We'll talk about a focused head and neck exam, so what to look for on yourself or family members that may indicate an early stage head and neck cancer. So the question is, what is head and neck cancer? And these are tumors and cancers that start within the mouth, the throat, voice box, sinuses, salivary glands, or even skin. We classify and stage these cancers based on where they start. To give a brief overview of the anatomy, we'll start from a top-down approach. There are cancers that occur in the nasal cavity. This is the area that we breathe in our nose, between our eyes, and in our skull base. And that is further separated into the nasal cavity and paranasal sinuses. The oral cavity is one of the most common areas to have head and neck cancer, and that extends from the lips to the back of the hard palate. The pharynx, or what's commonly referred to as the throat, involves the soft palate, the base of the tongue, and our tonsils. We have the voice box, or larynx, which involves the vocal cords as well as the epiglottis and the structures that help us move our vocal cords. The hypopharynx is the area behind the voice box, but it involved more in swallowing. And then we have four major salivary glands, the two paired parotid glands, which sit in front of the ear and lateral to the jawbone, and then the submandibular glands, which sit just below the jaw and underneath the tongue. So we don't hear a lot about head and neck cancer on the news, and so we want to understand how prevalent is this. It's not as prevalent as, say, breast or lung or colon cancer, but still is a major problem in terms of identification and recognition. And so understanding the number of cases is important. And when we look at our statistics and data, there's about 90,000 new cases of head and neck cancer every year, excluding skin cancer. And importantly, what is the difference in terms of survival, quality of life, and cost of treatment comparing early versus advanced stage head and neck cancer? When all of these subsites are grouped together, we have some collective data that shows that there is a significant difference in survival when head and neck cancers are treated or identified and treated from an early stage, with head and neck cancer survival being around 80% at 5 years for early stage cancers versus about 40% at when found in a more advanced stage. This correlates with quality of life as well. The quality of life in patients who are treated for early stage cancer compared to advanced stage cancer is significantly better in the early stage cancers and this is primarily looking at speech, swallowing, and breathing. Do you need a tracheostomy? Are you able to eat a full range of foods, and is your speech normal? That's much better in patients who are treated with early stage cancer compared to advanced stage cancer. And there is a cost advantage for treating early stage cancer. Both this quality of life and cost advantages for treating early stage cancer is associated with the fact that early stage cancer can oftentimes be treated with single modality therapy. So the things that we use to treat head and neck cancer are surgery and radiation and chemotherapy. And if you can just use one of those to treat the cancer effectively, then you have a lot less side effects and a lot less cost. And there's also an increased survival. So advanced stage head and neck cancers often require surgery and radiation, or surgery and radiation and chemotherapy, or radiation and chemotherapy, compared to early stage cancers, which often just require either surgery or radiation. So we'll talk a little bit about screening, and just to describe what screening is testing the general population for a problem that is currently asymptomatic to them at that time. So imagine this would be a study that looks at everyone, say a certain age, that would help identify very early stage head and neck cancers. And unfortunately, we've looked at a lot of different data, and due to the relative rarity of the disease process, there's no current screening guidelines, and that's a unified thought between the United States Preventive Services Task Force, the American Head and Neck Association, the American Dental Association, and the American College of Surgeons. And so if you're asymptomatic, there's nothing that we can really rely on to accurately test from a blood test or imaging standpoint. So we have to rely on these risk factors and red flags that we don't want to miss. We do want to keep patients who have an increased risk profile, heavy alcohol and tobacco use, a history of HPV papillomas in their throat or tonsils, or prior head and neck cancer. We do like to watch those patients more frequently, but again, there's still no current screening guidelines for head and neck cancer. So what are the risk factors for head and neck cancer? By far, the biggest risk factor is tobacco use, either inhaled or smoked tobacco use, or smokeless tobacco, like chewing tobacco, is a significant risk factor for oral cavity, oropharynx, and larynx cancer. Alcohol use in itself has some increased risk of head and neck cancer. However, in combination with tobacco, so the combination of heavy tobacco and alcohol use significantly increases the risk of head and neck cancer to about 40 times that of the general population. One thing we don't think about that often, but we see frequently, especially in a head and neck cancer clinic, is patients without traditional risk factors, but who are developing cancers of their tongue or oral cavity due to conditions of chronic irritation within the mouth. So poor oral hygiene, especially cracked or broken or sharp teeth, can rub on the lining of the mouth in a way that precipitates a tongue, floor, mouth, or cheek cancer. So it's definitely something to be aware of. The human papillomavirus, this is something that we didn't recognize as a major risk factor until the last 15 to 20 years. And now this is the driving force behind most oropharyngeal cancers. And whereas tobacco and alcohol have become less of a component in those cancers, the HPV virus has shown to be the driving force for the increase in prevalence of oropharyngeal cancers. Prolonged and intense sun exposure is a risk factor for skin cancer and lip cancer, which behaves very similar to skin cancer. There are some occupational exposures. Anything with a very fine particle or dust can be irritating. This can occur in sawmills or woodworking shops. Some of the processing chemicals for wood products also can have a carcinogenic effect. The most common one is dichromate. Asbestos can affect the lungs as well. A history of prior skin cancer, especially if you get it in a large lymph node that doesn't go away. If you have a history of a prior skin cancer, especially if that skin cancer was above the level of that lymph node, is a risk factor for recurrent cancer at that local site or for skin cancer going into the lymph nodes. Patients who are immunosuppressed, so imagine like transplant patients or patients with immunosuppressive illnesses like HIV, are at increased risk of cancers because one of the things that keeps cancer at bay, and actually our body uses to fight cancer, is our immune system. So if you suppress that system, your risk of developing cancers, and especially cancers that grow rapidly, is increased. Chronic lymphocytic leukemia is a type of bloodborne cancer that puts you at risk for aggressive types of skin cancer. So we have a kind of extensive list of red flag signs and symptoms here. I won't go through them individually. We'll go through them on further slides, but just to have a single slide list of the main red flags, we wanted to have that here. So the first and probably one of the most important red flags is a painless, otherwise asymptomatic neck mass. So patients will often go months with these not knowing that they have it and then not discover it until they're shaving or a family or a friend tells them that they have a mass on their neck. Unlike infections oftentimes are painful and have red, come and go quickly. A persistently or slowly enlarging neck mass that is painless is cancer in an adult until proven otherwise. So these are often occurring when there's no other symptoms. So cancer, just to talk about these neck masses, that would represent an enlarged lymph node that's has cancer in it. So cancer doesn't start, or at least in the head and neck, doesn't start in the lymph nodes. It usually starts on a surface, so the skin or the lining of the mouth, the lining of the throat or the voice box, or in the nasal cavity. From there, small portions of that tumor or cells from that tumor can break off and float down the lymphatic system and then be caught by lymph nodes and then set up shop in the lymph node and then slowly grow as a painless neck mass. So if we see this neck mass, we want to start saying, what is it and where did it come from? The next one is ear pain. We commonly think of ear pain as an ear infection, so like a bacterial infection of the ear that creates pain. However, this is not always the source, and in adults, it's actually infections are a minority of cause of ear pain. But it's important to sort of understand some of the anatomy of the head and the neck. The nerves that give us sensation to our ear canal and to the area behind the eardrum are the same nerves that give us sensation to the tonsils, base of tongue, and voice box. And so tumors in the base of tongue or voice box or other parts of the throat can present as ear pain because it's irritating the same nerves that are giving sensation to the ear, so the brain interprets that as ear pain and not from the throat. So one of the classic stories is a patient that comes in has had 3 months of ear pain, has been on antibiotics and steroid and drops, but no significant improvement in their symptoms. Medical professionals have looked in the ear and not seen any infection. And so the question is, where is this pain coming from? We really need to start looking at that patient and evaluating the areas that could be harboring cancer that are hard to see from the surface. And in that situation, it's important to get that patient to their primary care doctor or to ideally an ear, nose, and throat doctor that can look at the very back of the throat and determine if there is something more aggressive going on. Difficulty swallowing and unexplained weight loss are also common risk factors for cancer. Dysphagia is sort of the fancy word for difficulty swallowing. Odynophagia means painful swallowing. And these both can lead to unexplained weight loss. So a kind of classic story is a patient comes in, I just can't swallow, I'm trying to get food down, but it really just won't go down. Or I've lost 40 pounds and I'm not trying, it just fell off of me over the last 2 to 3 months. Or it's really painful to swallow, especially if a patient can point to a specific area. These can be all indications of an earlier developing head and neck cancer. So this is common specifically in the oral cavity, the oropharynx, which again is the soft palate, base of tongue and tonsils, larynx, which is the voice box. And these create weight loss for two main reasons. One, if it's painful to swallow, people are eating less. And two, they can affect our swallow function by, one, directly invading the structures that allow us to swallow. So swallowing is a very complex coordinated movement that allows food to go from our mouth, essentially through our throat, into our esophagus, and into our stomach. If any of those structures are affected, that can create a dysfunction and food getting caught or just not transitioning down by direct mass effect. Or if these tumors are invading the nerve and that nerve is no longer functioning and directing the body how to move to get food down, then you can also have an associated weight loss. There are several lesions within the mouth that are concerning features that we as physicians will sometimes see and can be early warning signs of cancer or actually like a pre-cancer themselves. The first one is leukoplakia, which literally translates to white plaque. On the top left of the screen, we can see a patient sticking out their tongue, and there's this white plaque-like surface change along the what we call the ventral aspect of the tongue, or the floor of the tongue. That is oftentimes a precursor to a mucosal cancer or tongue cancer, and is usually a result of some sort of irritating factor, and that's the body's response to try to resist that irritation. About 10% of these will go on to develop into cancers. Sometimes a progression of this or alone, even without a preceding leukoplakia, is erythroplakia. Again, this means red plaque. So on the bottom left, we see a picture of erythroplakia, and this has about a 50% chance of turning into cancer, so much higher than leukoplakia itself, and that definitely needs to be evaluated. Both of these should be evaluated by an ENT, dentist, or oral surgeon to make sure that we're not missing something. The way that we typically evaluate those is with taking a small sample of those lesions and sending them to the pathologist for evaluation. Painful, firm, or ulcerated sores of the mouth that don't heal within 1 to 2 weeks are also concerning. Oftentimes, these can be associated with like bite trauma or a burn, but if they don't go away, oftentimes these represent a small cancer or tumor of the tongue or floor of the mouth. So on the top right, we see this picture of a tongue and this raised ulcerated lesion representing an early stage tongue cancer. The same thing in the floor of the mouth, the area just behind the teeth here, we see again this ulcerated, red, inflamed looking area. Again, this is an early stage oral cavity cancer. Things that should be biopsied and treated early so that it can minimize treatment effect and improve survival. A non-healing wound of the head and neck, so this is like of the skin of the neck, face, ears, especially in the setting of prior trauma or burns. Again, these are cancers until proven otherwise. So if the classic one is a patient will come in and say, I had a spider bite 3 years ago and it never healed, it stays infected, it's progressively enlarging. Well, oftentimes that's a skin cancer that is progressing and continuing to grow. The irritation from a burn or even a prior skin excision actually can precipitate development of a cancer or tumor itself. And prior trauma, even crush injuries or pinch injuries can lead to this. That chronic irritation that doesn't heal produces an environment that allows cancer cells to develop and escape the immune system and then once at a certain size, they can't, the body can't handle itself, and it turns into a more aggressive type of skin cancer usually. So anything that's not healing on its own in the matter of weeks to several months needs to be evaluated again by your PCP or ear, nose, and throat doctor to make sure that we're not missing an early cancer. Noisy breathing or a coarse or gravelly or even breathy voice can be early signs of a throat or larynx cancer. So our larynx does a couple things. The most important thing is it keeps food and drink out of our lungs. The second most important part of it is allows us to breathe and move air. And then the third function of the voice box is to allow us to speak. And tumors can develop on these on the surfaces of the vocal cords or within the structures of the voice box. And the picture on the right, we see a voice box, and on the right, we can see a relatively normal looking vocal cord, but on the left, we have this granular ulcerated lesion that represents a vocal cord cancer. And this is most common in people who smoke tobacco, and that chronic irritation then leads to a cancer. And oftentimes that will start with people will call it chronic laryngitis, which is an easy way of saying just irritation of the voice box, and it is irritation, but we want to make sure that we're not missing an early cancer. So a coarse, gravelly, or breathy voice, or even a wet voice, can be an indication of an early cancer and something that should be evaluated by a medical professional that can look at the voice box. And the way that we do that is with a small camera that goes through the nose, bypassing our gag reflexes, and allows us to see the voice box. These symptoms can also be a result of vocal cord paralysis. Small tumors on the vocal cords can invade the muscles that move the vocal cords, or even the nerves that give us movement to the vocal cords, and can be an indication of a tumor there. Noisy breathing is the result of air rushing through a narrowed airway. So if you hear someone with very noisy breathing, and especially if they're getting short of breath with exertion or with movement, then that person needs to be evaluated right away, and it would not be incorrect to have that patient seen in an emergency department setting or an urgent referral to an ear, nose, and throat doctor. Unexplained paralysis of the head and neck are another major indicator that something is invading those nerves and creating a problem and needs further evaluation. Facial paralysis, oftentimes called Bell's palsy, can be an indicator of a tumor that's invading the nerve that gives us movement to our face. So this is commonly seen in skin cancers or cancers of the parotid gland, that salivary gland that sits lateral to the ear. The nerve comes out of the skull base through the bone behind the ear and then supplies the muscles of facial expression. It can be injured anywhere along that course, but most commonly from a tumor or cancer that's growing within the parotid gland itself. On the picture on the far right, we can see a patient with facial paralysis. So you'll see loss of the crease besides the nose, drooping of the corner of the mouth, an eyelid that doesn't close, and oftentimes you'll see a red eye because inability to close the eye leads to chronic irritation of the eye. Another one is vocal cord paralysis. So if someone develops out of nowhere a very breathy voice, that means that their vocal cords can't close together and they can't speak efficiently given the sound of a very breathy voice. Or if there's, again, noisy breathing or stridor, that can be an indication that that cord is paralyzed, but paralyzed too close to the middle and is narrowing the airway. One of the other major nerves that we talk about in terms of cancer involvement is the hypoglossal nerve, which gives us movement to the tongue. So in the middle picture, or the picture on the left here, we can see a patient who's attempting to stick their tongue out, but it's deviating to the left, and the size of the tongue is much smaller on the left compared to the right side of the tongue. This is due to injury of the nerve that's giving movement to the tongue, and this can be from a tumor or cancer deeper in the back of the throat or in the neck. And we use the phrase, when there's a hypoglossal paralysis, you lick your wound. So the tongue will deviate towards the side of a nerve injury. Nasal obstruction, loss of sense of smell, and nosebleeds or epistaxis are also frequent signs and symptoms of a nasal cavity tumor. Tumors of the nose are very vascular and they have a very delicate surface, so they oftentimes bleed. That, in combination with their growth into the nasal airway, can create nasal obstruction. And because they're often invading the surfaces that harbor our smell receptors or blocking airflow to the smell receptors, can create a smell loss. So any of these singularly are not major risk factors for a sinonasal or nasal cavity cancer. However, if all three of these are present, we have to assume that there's a mass or tumor there that's creating this problem and needs to be evaluated. Visual changes are another one. So there's several nerves that allow us to move our eyes, and then the nerve that allows us to see. All of these run through the back of the nose, face, and neck, and can be affected by tumors specifically in the nasopharynx or pituitary area or in our paranasal sinuses. And oftentimes patients will complain of double vision, especially if they're trying to look up or look to the side. If they are having double vision, you definitely look for asymmetry in the movement of the eyes. Our eyes rely on staying on track with each other to maintain a stable vision. If that changes at all, then you get double vision. A loss of vision itself can represent a tumor that's invading the skull base and pressing on the nerves that give us vision. In the picture we have here, a common one that is seen for cancers in the very back of the nose that push on the brain or invade the skull base is what we call a sixth nerve cranial palsy. So in this picture, the patient's trying to look to the left, and the patient's left eye is pointing to the, well, actually the patient's right, but the patient's right eye is not moving. So this would indicate that patient has a right-sided cranial nerve sixth palsy. But if patients are complaining, or if you or a family member is complaining of double vision, they have asymmetric eye movements, or a new onset vision loss, severe vision loss or blindness, then that definitely needs to be evaluated. You can see an ENT or an ophthalmologist for that problem. Now, talking about our salivary glands, the main thing to be looking for is visual enlargement or palpable enlargement, something that you can feel with your hands, and facial paralysis. These are warning signs that there is an aggressive process going on within that salivary gland that likely represents a head and neck cancer. Additional things that we need to be aware of are a painful parotid mass or submandibular mass, skin changes over the parotid mass, and rapid growth. So those are all risk factors. In the picture on the left, we see a patient who previously had a skin cancer in his scalp, was excised, and now has a parotid enlargement on the left, and that represents a cancer where cells from that previous skin cancer made it down to the lymph nodes and are now starting to grow. A similar thing in the picture in the center, we see a gentleman, and on the left temple area, you can see that there was a prior excision, and it looks clear there. However, he has a large parotid mass and facial paralysis. Again, we see that corner of the mouth drooping. There's the loss of the crease lateral to the nose, and that left eyelid is drooping, indicating that it's caused facial paralysis. So A rapidly or progressively enlarging mass of the product, again, needs evaluation by a medical professional. So if you see these warning signs, or if you notice these in yourself or any family member, what do you do? And so one, you have to look at a timeline. Any of these signs that are lasting greater than 2 weeks, you should make a significant effort to get into your primary care or to an ENT as soon as possible. Oftentimes, these early cancers are mistaken as infections, and they're treated with antibiotics and steroids. We typically recommend against that unless there is an obvious source of bacterial infection that would be treated by antibiotics. So just throwing antibiotics and steroids at it is not the appropriate move. And having it further evaluated is the best option. And the one other thing we would say about steroids is they can decrease inflammation, but they do that from immunosuppression, and that can actually accelerate the growth of small cancers into a more aggressive type of cancer because the immune system is no longer keeping it in check. One of the main things to be aware of from this lecture is any new painless neck mass in an adult is cancer until proven otherwise. That just needs to be looked at and evaluated, imaging done, and oftentimes biopsies performed to make sure that we're not missing something more aggressive. When you first notice these signs, make note of how long they've been going on, when they started, how they've progressed. Make note, do you have any of these risk factors? Combined tobacco and alcohol use, known HPV papillomas, and take pictures so that you can document the progression of this process. And that'll help doctors understand if this is something concerning or if this is something that's a benign process that we're just being careful with. And again, going back to the antibiotics and steroids, you don't want to treat and wait more than once or repeatedly. If something doesn't work initially and these warning signs are present, you don't want to keep treating it as if it's benign if we don't know. So it's important for these warning signs to be evaluated again by your primary or a ear, nose, and throat doctor to make sure that we're not missing something that can be treated early and with minimal risk. The take-home message: any of these red flags that last more than 2 weeks, get checked out. That oftentimes will lead to diagnosis, if it is cancer, at an earlier stage with reduced side effects of treatment and improved survival outcomes. Again, a neck mass in adults, cancer until proven otherwise. See a doctor early if you're concerned. If you're just concerned that there is something suspicious going on, definitely get checked out. And don't be afraid to reach out to your ENTs or head and neck specialist directly to schedule an appointment to get checked out for any of these red flag symptoms. I work at the Head and Neck Cancer Center at Ear, Nose, and Throat Associates based in Clearwater. We have our number here. Feel free to call to make an appointment if you have any questions, concerns, or concerning symptoms, and I'll open up the floor to questions.
Well, that was awesome. You brought so much good information out for us. I think one of the things, so those who've been on this call before know I've been on my own cancer journey over the last 2 years. So it can never be reiterated enough that early detection is key. If you're afraid or worried that something is going on, don't sit and worry about it. Go talk to someone who actually can give you an answer, because not only is it better for you physically and you won't have to deal with as much, it's a lot less cost for you also. So I love the fact that you talked about it in the beginning, you talked about it in the middle, and you talked about it at the end. So those are great. We will have this recorded for anyone who wants to re-watch this, and I will send out this information. So if you need to get a hold of anyone from the organization. We have a couple questions though. So how accurate is that machine they use in the dentist office to check your mouth for cancers?
Yeah, so it's a great question. We don't have a lot of data to determine that is a incredibly accurate way of screening. Again, screening, there's no recommendations for it. It is something that can give us a lot of peace of mind. The vast majority of patients who have that done will be negative. Occasionally, it can pick up something very small or an early change, but rarely we wouldn't rely on a positive study at the dentist with the blue light as a diagnosis of cancer. So again, it's trying to be used as a screening tool, and the way that screening tools work is they have a very high sensitivity, meaning that they will catch that, meaning that they'll very few things pass that filter that are cancer, but that means that there's also a lot of false positives, and you accept that just to make sure that you're not missing any of the bad ones. So it's not wrong to have it done. We don't have a whole lot of evidence to justify its use, but certainly if cost is not prohibitive, the risk is low, and it's not unreasonable.
What about in the dentist office where they just do a visual assessment on you and they're not using any sort of equipment? Same kind of thought. It's more of just a screening to say, hey, there's something.
Certainly. I mean, if you're at the dentist, it is their obligation to evaluate not only the teeth and the gums, but all of the mouth and throat. And actually, a lot of my referrals come from dentists and oral surgeons who incidentally find a mass or tumor on just visual examination of the mouth. So in general, as a physician, if you're working on a certain area of the body, you should examine that entire area. And if there's any concerning findings, present those to get that patient referred to the doctor that can treat it if it is something bad.
So when you're going for your preventative teeth care, don't forget to make sure they're at least looking everywhere around your mouth. Our next question is, should someone be concerned if when they're eating, they have difficult time swallowing, their taste buds are off, and it's immediately going through their body very quickly and out the other side?
Yeah, what we call a short transit time. So painful swallowing or difficulty getting food down is certainly a concerning finding and should be evaluated. However, once it's through the esophagus, if you're not absorbing it well, there are certainly a lot of different things that can cause that, and that alone. So a short transit time, meaning the time between eating something and then having a bowel movement, that's not necessarily indicative of a head and neck cancer. But I would definitely evaluate that either with your primary care doctor or with your gastroenterologist.
You had talked earlier about antibiotics and that we don't want to use those if we're not sure if there's a clear and present antibiotic. But let's say someone has cancer and they were given that antibiotic in error. Is that going to cause any problems with the individual?
Typically not. Sometimes patients will have, and whether this is true or not, or they just feel like they're doing something, they'll feel like they've had some response to the antibiotic and they feel like, oh, so it's an infection. In reality, it's not. And so, no, it typically does not have any deleterious effects on the cancer outside of oftentimes it can lead people to a false sense of security and a delay in evaluation and treatment.
Okay. We were talking about the dentist and the test, and I'm not sure if this is what it's called, but someone in the chat asked the ONOSURE testing, ONCOSURE testing. Have you heard of that? And what's the accuracy of that?
Yeah, so there's several different tests that the dentists use to evaluate for surface abnormalities of the lining of the mouth, and I don't know all the details and data on the specific ones. So I can't comment necessarily on the tools that they use. I do know that they are screening. They are attempts at screening tools. There's no recommendations for them. And again, it's not wrong to do them, and they may identify something early. But in terms of statistics behind them, I don't have the data on that.
So the key there is when you're getting these tests, don't get yourself overwhelmed, move to the next step and let the right professionals kind of keep assessing and figuring out what actually is going on.
Correct. If there's something that's concerning on that exam, then seeing an oral surgeon or an ear, nose, and throat doctor for further evaluation and possible biopsy are the next steps. But again, those screening tools are going to have a lot of false positives, and that's just how screening tools are designed.
One of the questions we got multiple times in the registration format is about head and neck pain, like they're having trouble sleeping because their neck is bothering them, and there's a lot of just pain. a lot of times people always go to joint pain with that or your cervical. Is this something that people should be concerned about maybe and have a different type of screening done?
Ear pain is more specific to head and neck cancer. Generalized musculoskeletal pain of the neck and jaw and face is less specific for head and neck cancer. However, if you can point to a specific area, you say I hurt, and then point directly right there, then that's something that should be evaluated. There are a lot of causes of head and neck pain, but the ones that are more concerning, for example, it's the patient who's otherwise really healthy, 55-year-old male, who just develops unilateral ear pain out of nowhere and doesn't have hearing loss or drainage from the ear, no other ear symptoms, just pain that they can't really explain. Generalized neck pain in general is less likely, but kind of those specific, if you have a specific spot that you can point at, or isolated or unilateral ear pain, are more concerning features.
Excellent. And to get your opinion on this, the dentist question comes up again. I know for me, again, because I've had some cancers, my dentist has always done an oral or a visual check of mine, even before I was cancer. Is that something that you're aware of that every dentist is doing or should be doing when you go in for your screenings?
Yeah. In general, if someone's working in your mouth, they should examine the entire mouth from the back of from the throat to the soft palate, the gums, tongue, floor of the mouth, and cheeks.
If someone's having some inflammation where when they eat something tart or sweet, is that something to be concerned about, or is there something to treat with that? Someone called it parotid inflammation.
Like parotiditis. So if you have an obstruction of any of the salivary glands and you eat something sour or tart, that salivary gland is going to continue to try to make saliva, and then the muscles that control release of that saliva will squeeze to try to get some more saliva out, and you can feel pain with that. That's not necessarily a warning sign for a head and neck cancer. That can sometimes mean obstruction of the ducts from small stones or just inflammation, but in itself is non-concerning. Definitely get that evaluated in a non-urgent manner. So you wouldn't need to go to the emergency department for that, but scheduling an appointment with your ear, nose, and throat, it's not unreasonable. But that symptom is not typically associated with a head and neck cancer.
Excellent. Well, we have finished our questions and we're right basically at time. So perfect. We want to thank you so much for sharing your knowledge with us today and giving us a lot of food for thought and giving us some direction if anything is going on in us, to always remember to reach out to the correct professionals so that we can get the care that we need. And we appreciate you very much.
It was a pleasure talking, and reach out to us if you have any questions.
Thank you, everyone. We'll see you again next month.
Thank you.